Good afternoon, everybody. This is Sush Prusty from MyHeartMD. Happy World Heart Day. Did you know that obesity rates in adults have doubled, and in children they have quadrupled? You know, it really has become a worldwide epidemic, killing more and more people every day, and really needs to be addressed, right? Matter of fact, obesity is one of the leading factors for several conditions, including things like heart disease, stroke, and also places a significant responsibility on physicians and clinicians in how they speak with patients with this particular problem. And sometimes, as we all know, this can be a fairly, sensitive issue. So we'll be touching on these points, discussing more about them. And then I'll get my guest on pretty soon. Just to review, my name is Sush Prusty, and this program is hosted by our good friends at Cardiovisual. My guest today, is Dr. Paul Tucker, and let's go ahead and bring him on.
Well, hey, how you doing?
Dr. Tucker, this was so easy.
After a little bit of trial and error, it was easy.
Just a walk in the park, right?
Yes, sir.
Right. So, Dr. Paul Tucker is our guest. He currently practices in Austin, Texas. He's an interventional cardiologist. Now, you have so many accolades that I can't go through all of them, but you have served 2 terms as chief of cardiology at St. David South Austin Medical Center, and you've been awarded the Texas Monthly Super Doctor Award, not once, but 19 times. And you are a Hall of Fame legacy member. Now, I want to know what that is, by the way. Take a minute now and tell our viewers about yourself and explain that to me.
Okay, sure. I'm an interventional cardiologist in Austin, Texas. I've trained down in Houston at the Texas Heart Institute with some famous people down there were Dr. DeBakey and Dr. Cooley. They're on the surgery side. On the cardiology side, my immediate mentor was Dr. Robert Hall, who was one of the founders at the Texas Heart Institute. So that's where I trained down in Houston, and then I've been in Austin since I finished that in 1993. So this is my 31st year here. So I've done everything from general cardiology to ER cardiology to cath lab, office, preventive cardiology, and post-event, like after a heart attack or stent or bypass, taking care of all those people. So really the whole gamut. The Super Doctor thing is an award that is given to the top 5% in any particular area in Texas of vote getters, if you will. And the people who vote are other doctors. So basically what they do is they ask other physicians, which cardiologist would you see if you had to go see someone yourself? So it's not a patient thing, it's a peer-to-peer type of award. So what happens is the top 5% get named each year. And if you get it 10 years, then you're a Hall of Fame member. And if you get it 15, then you're a legacy member. And you get a nice certificate. but more important, honestly, than that is just knowing that my peers, at least some of them, would choose to see me if they had a heart problem. And I have seen a fair number of my peers. So that's what the award means, to keep it simple.
Yeah, that's pretty incredible. It really is a huge honor, and a huge honor for all of us to have you here. So thanks
Thank you
thanks
again
for doing it. Now, heart disease, as everyone knows, is the #1 killer, with deaths in the U.S., and not just the U.S., but worldwide. It's something like accounts for 1 out of 5 deaths. I think it might be more than that, actually. And there's also a tremendous cost burden, right? Over $2 billion, I think, a year, something crazy like that. Let's just start simple and kind of guide us through some of the traditional risk factors for heart disease.
Sure. The most common things are high blood pressure, history of smoking, diabetes, family history, and high cholesterol. The medical term for that is hyperlipidemia. And sort of entwined in all of that is what we're talking about today, which is obesity, because obesity factors into all of those things. So many patients who are overweight also have high blood pressure, also have type 2 diabetes, also have high cholesterol. But there's another component of that, which is the inflammation that goes along with obesity.
Right. Yeah, something insane like, 300,000 deaths each year due to obesity. I can't believe those numbers, really, quite frankly. Tell us about this. Why is obesity associated with heart disease, and is there a direct link to heart disease?
Well, I think, yes, as I was saying, obesity, when you're carrying around that excessive weight, your heart's working harder. And when that happens, you tend to develop higher blood pressure. Certainly not all obese patients have high blood pressure, but I would say a majority of them do. Many obese patients have high cholesterol. Many of them have elevated glucose to the point of either being pre-diabetic or diabetic. And then on top of that, uh, the excessive fat cells, the adipose tissue, especially if it's in the abdomen, as compared to like the hips or thighs, but especially if it seems to be the truncal obesity or in the abdomen area, those cells, those fat cells are not just sitting there, they're actually metabolically active and they actually create inflammation in the body, and you can measure that. There's blood tests that can measure it, such as the CRP or maybe even the myeloperoxidase. And there's probably other markers we don't even know how to measure.
Right.
But the reason the inflammation is important is we know that most heart attacks are caused by inflammation in the artery to the point that that plaque inside your heart artery goes from being a perhaps very modest narrowing, 20 or 30% narrowed. And if it gets inflamed and that plaque ruptures, it can go to 100% blockage in a matter of minutes. So there's a big inflammatory component to heart attack, or heart attacks, heart disease, and strokes. And that's, I think, why obesity directly, all by itself, even if you didn't have any of the other three risk factors, which would be unusual to not have any of them, but just obesity by itself causes inflammation, and it can lead to these problems.
Right. And you mentioned the abdominal fat being metabolically active, right? I'm
Right.
assuming what you're saying, correct me if I'm wrong, you're saying the fat in this part of the body can now generate free radicals and things like that. Is that what you're saying?
Yeah, that may be one of the mechanisms. I mean, we could kind of get into the weeds of it all, but uh, suffice it to say that truncal obesity is worse than hips and thighs, so to speak. An article I read said, well, it's either the apple shape or the pear shape, the apple being the truncal and the pear shape being kind of the hips and thighs and rear end.
Right. Right. And just for our viewers here, Dr. Tucker, can we touch on some other things besides obesity that put people at risk for heart disease?
Yeah, well, there's so many
Hmm.
in our Western civilization, so to speak, but it's really all over the world now. It's not just Western civilization. So if your blood pressure is not controlled, it puts more stress on your heart. The high blood pressure itself literally can cause damage to the arteries of your heart, and your brain, why it can lead to stroke, whether it be from plaque formation or rupture of a brain artery, which is called an aneurysm or hemorrhage. So that can do it. Diabetes directly damages the arteries when the sugar is high and it's uncontrolled. That leads to a lot of actual inflammation in the arterial wall, which can be measured. Smoking directly damages the artery walls and can also contribute to plaque formation. And then on top of that, you've got a family history, which you can't really control, right? You can't control what your genetics are, but there's definitely a strong component. I mean, every cardiologist can tell you they've seen patients with multiple risk factors who managed to just get into their late 70s or 80s without a problem, but then we also have those patients who have the really, really positive family histories. And to us, a positive family history is perhaps a male relative in their early 50s or female relative, first degree relative in their early 60s or younger that had their first heart problem.
Mm.
So someone in your family who had a heart attack in their 80s isn't really a risk factor for you. But someone in your first degree relative, mother, father, brother, sister, who had their first heart event in their, let's say, 40s or 50s, that's a risk factor.
Is there a number? Is there an age, like a hard age number?
Yeah, I mean, typically what I've read is 55 or less for men. So if you've got a first degree male relative, again, typically your father or your
Right.
brother. If it's uncles and cousins and grandparents, not so much of a risk factor. But that first degree relative is the key. And for women, I think the number would probably be under 60 because, as you probably know, because of estrogen, women tend to, and estrogen tends to be protective to the heart arteries. So women tend to have their heart problems a little bit later than men, frankly, after menopause when their estrogen levels drop and they don't have that cardio protection from that.
Yeah, and that makes a lot of sense actually, given the estrogen factor. And also, I'm seeing a lot of comments here, guys, about plant-based diet. Great questions. We don't have time to go into all the questions, but it does make sense that certain food types can actually help you, right? Be
Sure.
cardioprotective.
Right.
So, can we touch on that just a little bit?
Yeah, I think one of the things I like to recommend, I mean, as you mentioned, we could go down the rabbit hole of all the different diets that are
Right.
out there, but a particularly heart healthy diet is the Mediterranean diet, which
Mhm.
is rich in plant-based foods like legumes, nuts, vegetables. To some degree, certain dairy is okay, like cheese and whole yogurt. Extra virgin olive oil is a staple of that diet, super helpful. And the red wine that is frequently part of the Mediterranean diet, it seems to be somewhat protective too. So it's kind of those types of things, and it's certainly less of the red meat, bacon, that kind of thing. Less of the marbled, high saturated fat type of meats and proteins that are pretty popular here in the U.S.
Yeah, really a growing body of evidence about diet and what diet does for our heart. And there's
Mhm.
also stuff out now, I'm sure folks know that what's good for the heart is also good for the brain, turns out, because
Yeah,
it's a vascular
sure.
problem in many ways, right?
Yeah.
So,
And I should have mentioned avocados in there. That's part of the Mediterranean diet. And avocados, yes, they're high in fat, but it tend to be pretty high in good fat and omega-3s. So just avocados are pretty good for you unless you have really high potassium levels for other reasons.
mhm. So not so much, you're saying not so much an apple a day, but an avocado a day. Maybe that's too much.
Maybe a little too much, but maybe a couple times a week is certainly good.
Right.
Since we're talking about diet, if I could give you 10 seconds of what I think people should
Absolutely.
do.
Yeah.
I think people should do about three different things. Eat real food, not processed food, exercise, and try some intermittent fasting. And we can talk about that. But there's a lot of benefits to those three things. Eating real foods, meaning it doesn't come in a can or a box or a bag. You get it in the perimeter of the grocery store. That's where you see your fresh fruits, fresh vegetables. If you're going to have bread, get the freshly baked bread that's made right there that day in the bakery. And we all know how quickly it gets stale, right? In just a day or two, because it doesn't have what? All the preservatives. So you're wanting to avoid all that fake stuff, the processed food and the extra sugar. I mean, everyone has a little bit of a sweet tooth. I'm guilty. I'm not saying you can't ever have a, chocolate chip cookie, but you need to be, careful with that kind of stuff. So just less sugar, more real food, exercise daily, try to do something every day, even if it's just a stroll. And then intermittent fasting is a good thing to do several days a week. If you can do it, it's not difficult, and it can really help.
That's great advice. Really is fantastic. And this is a topic we can come back and discuss in detail. There's a vast amount of information on this that's just growing right now. So thank you for that. Let's talk a bit about some of the treatment challenges.
Mhm.
Now, I'm an ER doctor, right? So I don't have an office practice, but I'm really interested in knowing what are some of the challenges that you see, not acutely, but in your office, right? And what I'm
Yeah.
talking about is this: patients coming in to your office with obesity. In terms of, are there differences between obese patients and non-obese patients in regards to physical limitations, medication non-compliance, follow-up non-compliance, and other, managing other comorbidities? What's your
Yeah.
thought on that?
Well, I wouldn't to kind of start with the back end of that first regarding non-compliance. I think patients of all types and varieties can be non-compliant. I don't think overweight or obese patients are more likely to be non-compliant than anybody else. In terms of how we approach that in the office, everybody's got a different perspective on this, but um, just about every patient who comes into the office, you know, if they're on blood pressure medicine or their blood pressure is borderline, I say, are you checking your blood pressure at home? Are you exercising? Tell me what you do for your exercise. Tell me a little bit about your diet. And some of the patients who are overweight, and by the way, we consider overweight BMI of 25 to 30, and above 30 is obese, and then like 30 to 35, 35 to 40, 40 and above, you know, mild, moderate, severe obese. So anyway, anything over 25, which by the way, if you ever look it up, 25 is pretty tough to achieve for most people. So having said that, a lot of the people who come to the office who want to talk about their weight, and maybe they're a little bit afraid to bring it up, if they're afraid to bring it up, the way I kind of sort of ease into that is just start asking them about their habits. Tell me what you do. You know, don't start, you know, berating them about being overweight. That's not going to go anywhere. And, you know, there is a definite genetic component to obesity. So a lot of people truly can't help it. But they can definitely respond to what maybe they got from their mom or dad and make positive changes. So I'd ask them about their diet. I ask them about their exercise. I ask them about other habits like smoking. Do you monitor your blood pressure? Tell me what you do. And that frequently leads into the things that we want to talk about that will help them lose weight. And then there are some people, as you know, who come in and maybe the first thing out of their mouth is, you know, hey, I know I'm overweight. I know I'm way overweight, and I really want to get a handle on this. I'm tired of this. How can you help me? And it's for those people, it's still sort of the same discussion, but they brought it up rather than me bringing it up. But and there are easy ways to discuss it.
Yeah, you know, we talked a bit about this and what a challenge it can be for some people. As an ER, in the ER, there's not so much for discussion. There's no time for it, obviously. But what primary care doctors do, what you do, is profoundly impactful on patients. So
Yeah.
great points that you bring up. All right, Paul, we talk about a case.
Yeah, sure.
Um, I'll give you a case. This is a patient that we had a few years ago, 45-year-old female. I think her weight was 140 kilograms. Came into the ER. She had comorbidities like hypertension, she had diabetes, hypertension, history of CHF. She came in frequently, like over 100 analyst visits a year. But this time, she came in with chest pain, and EMS saw her appropriately after the cath lab, pre-hospitally, came in with an ECG that showed clear-cut STEMI, inferior escalations, tombstones, and she's having a STEMI. We called our cath team. You know, cath fellow comes down with the attending, evaluated her and said, yes, STEMI, cath lab. Now, from an ER standpoint, our job was fairly straightforward. You know, we stabilize, we give the initial medications and so on. As the cath lab attending, that you're taking this patient to the cath lab, what are some thoughts that go through your head, given the fact that she weighs 140 kilograms, you know, specifically in terms of, you know, airway, anesthetic access, things like that?
It can be challenging. You know, 140 kilograms would be, you know, 300 pounds roughly,
Sure.
you know, and so fortunately, cath lab techniques have evolved in the last 15 years or so, where we're doing a lot more radial artery catheterization. So even in the morbidly obese, that has reduced significantly the bleeding problems. If you did a heart cath on a person like that from the femoral approach, which is in the right groin area, that the artery can be very deep, and it's wonderful if you get the artery on the first stick, so to speak, and all that. But sometimes it's not that easy to locate that artery, even with ultrasound, and so you can end up with a much higher risk of bleeding from the groin approach versus the wrist. So having said that, let's just say you're able to get the wrist done. You've still got a patient who's having lots of chest pain. They're uncomfortable. They're frequently moving around. And at the same time, you're trying to get them relaxed and get them sedated. But you also have to worry about, how much sedation can I safely give this person? Because maybe a lot of the people listening don't realize if you have a heart attack and you're coming to the cath lab, you're not put under a general anesthesia. Except under the most extreme circumstances, like if you actually had a cardiac arrest or stopped breathing. In most cases, the vast majority of patients with heart attack, they're just treated with what we call conscious sedation. So you're awake, but just barely. You're kind of in twilight zone. You still can maintain your reflexes, but you can cross that line very carefully with just a little bit extra medication to where the patient is breathing and they're relaxed, to where now they're not breathing so well just because the thickness of the airway might be closing off because of the weight, that kind of thing. So now you're dealing with kind of two problems, an airway issue as well as getting access and getting the heart catheterization completed and getting the blocked artery open. So that's a challenge. Sometimes imaging can be difficult, getting these patients in and often on a stretcher and getting into a MRI or a CAT scanner. It frequently requires quite a few people to do that. Nevertheless, having said that, we're generally pretty successful at it. It's just, it can be more difficult, and there are some real issues. And on top of all that, the more overweight people tend to have just a slightly higher risk of complications from anything we do in the medical world.
Of course. Yeah, great points to bring up. Really fantastic and very important. I know that we touched on this before, but it's an important point, and I want to go back to it a little bit. Many would argue that, these patients, obese patients, speaking with them about obesity is a challenge. For some, it's a very sensitive issue. Can you give us some pearls of wisdom, some strategies on how to broach the subject if they don't bring it up, like you said, in your office?
Well, again, sometimes I ease into it just with talking about what their risk factors might be. And other times, I kind of use the we approach, rather than, well, you need to do this and you need to do that. It's like, I'm here to help you. I want to help you achieve your goals. Is one of your goals wanting to lose some weight? And most people honestly will say yes, and we'll say, okay, let's talk about how we can do that. Or I might even not even use the term weight. I'd say one of my goals is to help you feel better. I'm assuming you want to have less trouble on your joints and, breathe easier when you're walking up, a flight of stairs or on vacation. Is that something you would like? And most people would say, sure. Yeah, that's exactly what, I'd like to say. Okay. I say, well, here's what we need to do. And of course, if someone is really severe in that truly obese range or in the moderate or severely obese range, it can be daunting for them to think about losing 100 pounds. So rather than talk about that, I try to give the patient a realistic goal. I say, I'd like you to lose 1 pound per week for the next 2 months and come back and see me. And let's see if you're down 8 to 10 pounds, just 1 pound a week. That's all. That's your goal. Don't worry about what you see on TV and all of the different medicines and surgeries out there for weight loss. Just concentrate on this 1 pound a week, and you can do it with these things that you can do. Less sugar, less processed food, a little bit of exercise, maybe try some intermittent fasting, that kind of thing. You'd be surprised how easy it is to lose 1 pound. But trying to tell anyone, hey, I want you to lose 50 pounds or I want you to lose 100, that is almost defeating. I mean, they walk out of the office and go, I can't do that. But if you say, I want you to lose 1 pound between now and next Friday, I can do that. And then you say, by the end of a year, you might be down 50 pounds. How would that feel? And by the end of another year, you might be down 100. We've got time. So let's just take our time and get it done.
Yeah, that's a great approach. I think James Clear, I believe, wrote in his book, Atomic Habits, something like that. He talked about the cumulative benefits of incremental gains, something like that. And that's I try to use that. It's difficult to do or understand, but that's what you're talking about, right? Small changes over time instead of big changes. Short time. So, yes.
Yeah.
Great advice for our listeners. Thank you. I have a lot of patients who come to me and say, hey, I don't want medications. I don't want surgery. Lifestyle changes. What can I do just by lifestyle changes to make me come down that threshold of 25, BMI of 25? How successful are lifestyle changes solely without medication or surgery?
Well, it does truly depend on how motivated the person is and how disciplined they can be with these things we've just talked about.
Mhm.
So, turning away from the second portion of a meal or the dessert, really committing to exercise. Really, and by the way, people, when I say exercise, people think of running laps at the high school or at the local track or whatever. No, I'm just saying do something. 30 minutes of walking, stationary bike. Walking's actually wonderful. There's studies that just show people who can walk 40 to 45 minutes a day almost always lose some weight, and in fact, significant weight if they do it every day. So I said, whatever you do something. It's kind of, I don't want to say it's my mantra, but I've adopted it, which is move or die. Okay. And that's for all of us. God gave us these muscles and joints and brains to go do something, so use your muscles, get out there and exercise some, whatever you can do. People may have bad knees. They say, I can't walk. I say, okay, great. What about water aerobics? Puts very little weight on your knees. What about swimming? What about just doing mostly upper body stuff, with, weightlifting and stuff like that. There's lots of things, yoga, Pilates, there's lots of things people can do that are not going to hurt their joints.
Yeah.
So, so that's what couple lifestyle things.
Yeah. Yeah. Let's talk about the other stuff besides lifestyle. There's medications, a few medications out there now, and surgery. Which is appropriate for which kinds of patients?
Yeah, I think if you could take the last part first, like bariatric
Mhm.
surgery, whether it be, that used to be that there's the band and then there's the sleeve and then of course gastric bypass. Uh, I don't want to come across as necessarily an expert in those types of things, but I will say that those to me would be reserved for the most severe cases. So I mean, if you're gonna, because those are permanent, uh, semi-permanent to permanent alterations of your GI tract. Okay, your stomach's going to be smaller. You're going to be full much more quickly. You've got potentially the risk of surgical complications. Having said that, those surgeries can be life-saving. I've obviously, and you probably have too, seen patients in my practice who've lost over 100 pounds, some of them 200. They started at 450 and now they're 250. And for those people, I guarantee you it saved their life.
Yeah.
Um,
Yeah.
but let's say you've got the person who's 40 to 50 pounds overweight. I think the surgery in that person would be just a touch too much. Okay, I think we start with these other things first. I know there's going to be a presentation at a later date about the Ozempics and Manjaros of the world, and I'm not going to. I think you said we weren't going to really go into that. Those can be very effective though for that group of people. But I promise you, you can get the weight down without those meds by just having some discipline about your diet and your exercise, and and just really watching the things that are not good for you, avoiding the processed food, having real food in your diet. And I don't know if you want to even talk at all about intermittent fasting. I could explain probably in
Go,
20 seconds what it is.
go for it.
Yeah,
Absolutely.
I mean, intermittent fasting, there's a number of different ways to do it, but the bottom line is you're trying to give your body basically around 16 hours a day. If you can do 18, even better, where you're not eating. So typically what that means is you'll skip breakfast. You'll just have water in the morning or black coffee, without sugar. And then at noon, you'll have a lunch. At around 5:30 or 6 p.m., you'll have your dinner. And then after that, you go that night until the next day at lunchtime, which will be around 17 to 18 hours before you eat again. You can have all the water you want, but it seems drastic, but it really isn't. I do it myself when I want to lose a few pounds, and it works. And I've seen people lose the types of weight we're talking about. I've seen patients lose 100 pounds with intermittent fasting. And it should be monitored. You should have your doctor checking your electrolytes, magnesium, vitamin levels, B12, D, et cetera. And you need to be making some healthy choices in the meals you are having. But there's something about that 16-hour fast. So what happens is the liver the sugar that's stored in your liver is glycogen. Your body goes after that first to find a fuel source. And so one of the things that happens with intermittent fasting is there's a reduction in in your fatty liver if you have that, because you're going to start removing all that sugar out of your liver, which can in turn become triglycerides and fat in your liver. So you're going to remove that. And then once you've done this for a few days and you don't have any glucose stores left in your liver, where your body is going to start burning fat. And so you will start burning fat, and it will happen. It's at the last few hours of that fast is where the fat burning is the most accelerated. So I think intermittent fasting is really good for weight loss. There's multiple other benefits. We probably don't have time to go into it here, but it's been shown to help with the immune system. There are some studies that show it helps reduce and actually helps treat people with cancer, believe it or not.
Yes.
There's something that happens when you're intermittently fasting. One of the there's some cells that we all have circulating in our bodies that are either dead cells or nearly dead cells, and sometimes those cells can mutate and do bad things and become cancer. They can do that kind of thing. And one of the things that happens with intermittent fasting is called autophagy, AUTOPHAGY, which means your body starts eating those bad cells and destroying them, taking care of them. That might be one of the mechanisms where inflammation is reduced. There's studies that show intermittent fasting helps with arthritis. It helps with prevention or even treatment of cancer. Again, I don't have time here to quote all those studies for your audience, but they're out there and you should look at it. And as we know, for thousands of years, multiple different faiths and religions have practiced fasting as a way to clear their mind and, become closer to, God, et cetera. So there's a long history of this, in multiple religions. So it's kind of an interesting thing to explore.
Very, very, very interesting indeed. Speaking of intermittent fasting, I don't see very many patients who come back to the ER saying, "Hey, doc, thank you for having me lose weight," right? But I do sometimes. And when that happens, it's incredibly gratifying to see that a patient who has come back several times has now lost weight and it's changed their lives. And we love seeing all that, right? We love seeing our patients getting better and doing well. Can you share with us a couple of your stories of the success stories of how patients came in and they lost weight and how it changed their lives, not just physically, but emotionally, psychologically, things like that?
Well, yes, I can't name names, but a couple of my very good friends that I've known for years have been on this journey and had the gastric bypass, for example. These two guys I'm thinking of, they happen to be friends with each other, but they were, 350 to 400 pounds and headed down a very bad road. Okay. And I see both of them and have seen them both through this whole journey from when they were very, very heavy and in very bad health to where they are now. And one of them is truly at a normal weight and says he feels the best he's ever felt in his life. When he was heavier and was at the beginning of all this, he came to me because he wanted to get his heart checked out, and it turned out he already had heart problems. So we got him fixed up. He ultimately had a bypass, but this was kind of in the early part of all that. But he's done great ever since he's lost all that weight. And the other gentleman that I'm thinking of, and there's a bunch of them in my practice, but the other gentleman, he hasn't lost quite as much as the first guy, but he also did lose a lot, and he feels great and he exercises. And I mean, just everything is different. I mean, when you do get that weight off, you can start enjoying some things more. Your joints don't hurt as much. The orthopedic surgeons say if you lose 20, it feels like 40 to your knees. That's what the orthopedic surgeons say. I mean, if you think about it, it makes sense because you're walking on one leg at a time, right? So if you lose 20 pounds, all of your that's a net as far as your knees feel. It feels like it's less like you've lost 40. But think about, getting on and off of airplanes or buses or public transportation or traveling. And let's say you're in Europe where, as you know, there's lots of walking. Well, what if you can't enjoy that because you just can't do it because of your joints or you get so out of breath? So these are all good reasons It just, these people enjoy their lives more, and they obviously they feel better, and I think they have for sure a lot less health problems going forward.
Yeah, they do. They do. Really so true, right? Really, it feels so good to know that you're just part of their journey too, right? It really is good. Folks, we would like to take questions from you. I've seen so many questions on the feed here, scrolling right by me on intermittent fasting, dieting, plant-based foods, all these things. We're going to try to take some questions, I think. Dr. Tucker, if you have time, that is. Let's go ahead and see if we can get on a couple questions here while we pull them up. Let's see here. But in the meantime, while we're doing that, I want to thank everybody for joining this session. The problem of obesity is not getting better, it's getting worse, right? And it's getting worse not just in the US, but globally. And it is incumbent upon us to really be, as clinicians, to be part of the solution, I think. And that's what we're all about. And physicians too, and clinicians have this unique challenge in how do you coach and speak with patients who have this sensitive spot, obesity. And so that's also sort of a compounding challenge that we have as clinicians. So a huge thanks to you, Dr. Tucker. This, by the way, this talk is going to be on Cardio Visuals, multiple platforms. So stay tuned for that. You'll be able to see it again on all your other channels. And while we're doing that, let's see if we have any questions coming from the audience. I saw one question about plant-based diet, Dr. Tucker. What can you tell us about plant-based? There are like 3 questions about plant-based diets. How effective are they? How good for the heart are they? It's hard to do, right? Plant-based diets?
Well, they are if you're someone like me who grew up with, meat and potatoes frequently at the dinner table. That's not uncommon in America to have grown up with that. But plant, it's, the kind of one of the original big gurus, if you will, on going to a plant-based diet or a vegan or vegetarian diet was Dean Ornish, and Ornish. I mean, he had a book that I don't know how many millions of copies it sold. It's a tough diet. It's pretty Spartan, but you can get your cholesterol down and you can reduce your risk of future events following something like that. One of the things I also tell my patients is, although I know that people do lose weight on them, I personally am not a big fan of a 100% ketogenic diet because I don't think they're sustainable. I haven't found anyone who could do it forever. There's plants and carbohydrates and other stuff out there that our body needs. And the other thing that typically happens with the keto diet is patients, for their keto choices, tend to not necessarily make the best choices. So instead of having grilled fish, grilled chicken, lots of plants, it's for their keto, for their calories, they're getting meat, eggs, potato, cheese, and bacon. So they might lose weight, but their cholesterol frequently goes up, sometimes goes up a lot. So you're kind of robbing Peter to pay Paul, so to speak. You're maybe trading one problem for another. Not to mention, and there's no doubt about it, you will lose weight if you go into ketosis. The problem is just maintaining that long-term as a lifestyle. So I tend to say what we've said at the beginning of this,
right,
which is eat real food. If you're going to have, just a little bit of advice, if you're going to have red meat, have this red meat. Make sure it's grass-fed. Make sure it's a tenderloin, like a filet or tenderloin, because that's one of the leanest part of the cow. And make sure that it's cooked medium. And if you look at a filet as compared to a ribeye on a platter, there's no comparison in how they look. The ribeye is loaded with fat. You can see the fat in it. Whereas if you're going to have the grass-fed tenderloin or filet without the bacon wrapped around it, you're going to find that that's a fairly lean cut of red meat. A lot of people don't know this, but there are farmers who, of course, we've all heard about corn-fed beef. There are farmers that feed their cows candy because it makes them fatter, and they become worth more at the market. So I come from a family of farmers, so I'm not knocking farmers, but sometimes, there are things in the diet of the cow that are not good for them, and it's not good for us either. So you're eating kind of what they're eating.
Yeah. You know what? Christmas time, one candy cane for your cow. I don't know. I think it's getting
No
around.
problem. But again, I think there's a famous philosopher, Aristotle, who said everything in moderation. I think in America, especially, we could do a lot more things in moderation, which is, when you sit down to a meal, one of the things that a little trick that I have and my wife has, we almost always split entrees.
Mm,
So if we're at a restaurant and it's a 8 or 9 ounce fillet, we'll split it. And you might think, oh, that's only 4 ounces. You'd be surprised. Between
mm.
that and whatever sides you get and all that, glass of wine, you're
You're
full.
full.
Okay.
Yeah.
Yeah. So
Yeah.
splitting entrees is a good trick you can do, and it saves you money. But really, you just get less calories, and you'd be surprised. Hey, I'm actually
Yeah.
full. You split entree, split aside. So it's just a thought.
Yeah.
Two other sources of meat that are good. I know you probably got to go. Bison is a really good choice of red meat, and elk is really good. There's not
Okay.
much elk here in Texas. We certainly have plenty of venison. But if you're ever up in Colorado, Wyoming, Montana,
No
or
kidding.
the Western U.S., elk is a very good
All right.
meat. Yeah,
I'm going
very
to keep that
lean.
in mind.
Yeah,
Elk and bison. Have had
yeah.
neither one, but I'm open to it.
Bison is
Um,
actually, you wouldn't know the difference if you're having a bison burger versus a beef hamburger. At
is
least
that
I don't. I can't
right?
tell the difference.
No
Yeah,
kidding.
and I get a bison burger every time I go somewhere.
All right. Hey, let's just take two more questions here.
Sure.
One is here we go. Does thiamin, vitamin B1, reduce the risk for heart disease?
There's been tons of studies on all sorts of different vitamins, and my short answer is, to my knowledge, I'm not sure that taking a vitamin B1 supplement is going to significantly reduce your risk of heart
Mm,
disease. All sorts of vitamins have been looked at,
okay.
vitamin E, vitamin C. Um, they all have various uses, and they're important for our bodies. But the big one for years was vitamin E and even folic acid, because it reduces your homocysteine levels, and homocysteine is felt to be one of those markers of inflammation. But yet the studies haven't really borne that out, that folic acid, vitamin E, B1, B12, taking extra, you know, really making a significant impact on heart disease.
Right. Yeah. Thanks. Another question here. What is the ideal BMI to reduce heart disease?
Oh, I think the BMI needs to be, if you want to be truly reducing your heart disease, you need to have a normal BMI, which is 25, I think, zero point 0.5 or less.
Yeah.
Some people say it's 25, but
Yeah.
on my Epic computer, it says 25.5 is the goal, you know. But hey, look, but again, it's small victories, right? If you're
Hmm.
at 35 and we can get you down to 33, that's a huge win. Okay,
Yeah.
that's a significant, that's a almost 7-8% reduction in your body weight. And if we can get you from 33 down to 31, yeah, you're still obese. Who cares what the name is? You're still healthier.
Right.
Okay, so let's work on that.
Right. A great question, Scott. I saw a question about multivitamins recommended for heart health or not.
Like
I
I
don't
said,
know.
if you're getting enough vitamins in your diet,
You don't need
otherwise,
them.
probably not.
Yeah. Yeah.
It might make you feel better. It'll certainly make your urine very healthy, but because you're going to be peeing it all out. Okay.
Right. Right.
Yeah.
Listen, this has gone on for about 45 minutes. I thank you so much, Dr. Tucker, for your time,
No,
folks.
it's been a pleasure. I hope just one person of whoever was listening, if just one person felt they got something out of your discussion and mine, then it was worth it. So that's the way I look at it.
Absolutely, and there were several people out there who actually joined up, and great questions, folks. We will have more of these. Just a reminder, reminder that Cardio Visual will be posting this on their multiple websites, multiple sites rather, and platforms. So stay tuned for that. And Dr. Paul Tucker, thank you so much for your time today.
Thank you.
We'll hopefully
Okay.
get a chance to speak with you again. Stay
Yeah.
tuned for the next talk, guys. This is Sush from Boston. So long for now.
Thank you.